next speaker, Andrea Zambrano, is going to be talking about DVT prophylaxis in cirrhotic patients, to give or not to give. That is the question.
I think if Shakespeare was alive, he would have the same question. It's kind of a big dilemma. We still struggle with it, especially in the ICU. So I thought it was an interesting topic. So we all know that cirrhotic patients have been told they have a bleeding diathesis, they have a coagulopathy, they're auto-anticoagulated, and there's a lot of things why we think that's true. So they certainly have small bleeds due to like platelet dysfunction, such as gum, epistaxis. Those are very common. We have the most fear complication, which is esophageal bleed or esophageal variceal bleed. And then we have other complications of the bleeding, which are soft tissue hemarthrosis. So we always think, well, these patients are auto-anticoagulated, they tend to bleed, and that's why when they come to the hospital or even on the outpatient setting, we fear giving heparin or even warfarin to these patients. So should we be worried about DVTs in these patients and even like when they're in the hospital? So just a brief reminder about the coagulation. So we know what a blood clot is. It's formed by activated platelets, red blood cells, and fibrin, which bonds a clot. And then we have certain anticoagulation factors, which are the antithrombin, protein C and S. We have Adams T13 and PI, which is the plasminogen activator inhibitor. And this is relevant because in liver patients or in cirrhotic patients, we're going to see which ones are elevated or low. So in general, we see here this slide, which shows that a lot of the coagulation factors are synthesized by the liver. So factor 1, 2, we have 5, 7, we have 9, like all of these that are pointed out, except the 8, which is also synthesized by the endothelial cells. So in a regular coagulation pathway, we have both the intrinsic and the extrinsic pathway. Well, I've circled where heparin interacts. So heparin basically promotes antithrombin. It also blocks fibrinogen, and it also acts on factor 8, which is increased in cirrhotic patients. And all these lead to a formation of the blood clot that we saw in the previous slide. So this is the main point of my talk. So we can see what factors are actually increased or decreased in cirrhotic patients. So we know that there's some hemostatic factors. So for example, platelets are decreased, and it's multifactorial. We know that portal hypertension leads to splenomegaly. They can sequester platelets, but also there's a decrease in production by the bone marrow because there's the factor that stimulates the production of platelets is decreased. So we also have fibrinogen that is low, and there's thought to be a hyperfibrinolysis in these patients. Factors, most of them are low, except for 8. And then TAFI, which is another factor, is also impaired in cirrhosis. We have anticoagulation factors, which are decreased. So meaning, if they're decreased, we tend to form more clots in these patients, which are the antithrombin, protein C and S, which play an important role in predicting which patients are high risk of bleed or not, and the Adams T13. And then we have some prothrombotic factors, which play a role that are always elevated in these patients, which are the factor 8 and the von Willebrand factor, which is upregulated sort of to balance the low platelet dysfunction. And again, it's synthesized by the endothelial cells, so it has nothing, or it's little affected by the liver. So these patients live in a state of, it's a very tenuous balance between anticoagulation and procoagulation. So this is just another graphic just to say which ones are pro and antithrombotic, but we went over it. So we can say that these patients are not necessarily auto-anticoagulated, but it's been recently redefined as a rebalanced hemostatic state. So, and most of these patients tend to live in a prothrombotic state, and that's why they don't bleed if they're cirrhotic patients, even long-term cirrhotics, because they're kind of in this fine balance. So even though their platelets are low, their factors are low, they're not actively bleeding every day. So they tend to be in a little more prothrombotic state. And this is why measuring PT, INR, bleeding time, like all these regular tests that we use to measure coagulation in normal patients, it's basically useless in cirrhotic patients. They're altered. So we have, how can we measure then the bleeding of risk or coagulation in this patient? So fibrinogen seems to be the thing that is most related to bleeding risk in this patient. So they are in a state, it's not called DIC, but it's advanced coagulation or advanced disseminated coagulation. And the fibrinogen tends to be lower than 120. So fibrinogen being normal, it's a reassuring thing, and it's been related or correlated with lower risks of bleeding patients. Protein C has also been shown to be correlated with the risk of bleed in these patients. So the lower this, the more bleed these patients have. And the D-dimer is shown to be more elevated in patients with thrombosis or thrombotic events than in patients with cirrhosis without thrombotic events. So these are factors and tests that can give us a clue whether a patient is at higher risk of bleed versus thrombosis, but they're not perfect either. There's other tests that have been developed or are being tested more recently, which are the SonoClot, the ROTEM, and the TEG. And these are basically bedside tests. It's a special machine, and they basically report, they put a probe in the patient's plasma, and it gives you sort of like a peak of the clot formation, and then it decreases, the peak decreases as the clot breaks down. And it can give you a dynamic idea of how long does this patient take to clot and how long is a clot breaking? So, is the patient at a higher risk of bleed or not? So they're more expensive. It requires special equipment and so on. But a lot of hospitals are actually using these tests on cirrhotic patients because it gives them a better overall idea of their coagulation rather than by measuring independent factors or other normal tests. I found a lot of studies. Unfortunately, they're mostly like small studies here and there about bleeding risk versus thrombosis risk. So the first one I wanted to talk about was thrombotic risk factors in cirrhotic patients with MELD scoring system. So basically, this study talked about how patients that have been diagnosed with cirrhosis and have had cirrhosis for longer periods of time tend to have higher risk of bleeding. But also they talked about the incidence of DVTs, and by DVTs we also think about portal vein thrombosis, not only PE or lower extremity DVTs. And even though it's more common to find bleeding complications from cirrhosis, the thrombotic complications are significant. And when patients develop portal vein thrombosis, that has been shown to have a poorer progression of their cirrhosis. So we do want to prevent thrombosis in these patients. Most of them also have bleeding and thrombosis at the same time. So we do have to weigh kind of the risk and benefits of giving anticoagulation or giving prophylaxis to these patients, because overall it will improve their mortality or morbidity. So what should we fear the most? Should we be more afraid of bleeding or thrombosis? So for bleeding, I divided it into the less severe and then the most severe cases. So we have that esophageal varices, obviously the most severe complication, happens in 20 to 30% of the cirrhotic patients. So it's significantly high. It has a 25 to 30% mortality once it happens. And this is kind of like a summary of all the studies that I read. I'll give you my references at the end. It has a 26% of recurrence rate. So these patients are going to be coming back and rebleeding. And it's correlated with underlying infection and markers for fibrinolysis. On the other hand, DVT or PE has been shown to be in 0.5 to 8.2% of patients, and this is for hospitalized patients, but it has an increased mortality. 17 to 19% mortality just by having these events themselves. Cirrhotic patients have a greater risk of DVT, and that has with an odds ratio of 2.1. They also have a greatest risk for PE. And then for pulmonary vein thrombosis, it's about 10 to 25%. Then we have other bleeds, going back to the bleeding side, that are less common, but also could be significant. So that are not variceal bleeds, like peptic ulcer bleeds, for example, 3.6 to 5.5%. We have portal gastropathy that is not necessarily, it is not a esophageal variceal bleed, and that one is also common. 80 to 90% of patients bleed because of this, and it's associated with chronic anemia in these patients. And then we have other types of bleeds, like lower GI bleed, brain bleeds and stuff like that are much less common. And then complications from invasive procedures, I couldn't find percentages, but they all talk about that are very low. So when we worried about like, oh, this patient's gonna get a PICC line or a central line, it's really, there's not been like significantly higher complications, and they're just described to be as very low, even though these patients have like high INRs, high PT, whatever. They're not as frequent and as important that, compared to the other bleeds. So I found this systematic review of deep vein thrombosis and PE in cirrhotic patients, and this one has a lot of literature in it. However, they only included, I think it was about 10 studies, and I've highlighted the ones I think they're more important. So most of them talk about like small studies. The 3 that I highlighted are population-based studies, so they're huge. They have a lot of patients that they studied. I don't see the exact number, but it's like thousands of patients. And they were able to determine that these patients which have, between, as I said before, between 0.5 and 8% of DVTs, PEs, their mortality is significantly higher than regular patients. And also, the morbidity, length of stay is also higher in these patients if it happens in the hospital. A lot of them talk about compared giving DVT prophylaxis versus not, and they couldn't find an increased bleed in the groups of patients that gave DVT prophylaxis versus not. So we're really afraid of giving it. We should be preventing it, but at the same time, it hasn't been shown to increase the risk of bleed in these patients. I found another study, so thrombosis and hemorrhage in critically ill patients. So this one, the population was a little different. They measured the Apache score and the SOFA score at the beginning. I think patients that had the higher rates or incidence of bleed had a higher SOFA score, so they were sicker to begin with when they came to ICU. They found that 45.5% were bleeding complications and only 13.6% were thrombotic complications. And then basically the association, the main factors associated with bleeding or thrombosis in the critically ill patients were infections. Bleeding and thrombosis were related themselves after taking out the other confounding factors. They also found that the bleeding and thrombotic events was, the association between both of them was statistically significant. This one, so here's just to see the characteristics. So the main admission to the ICU problem was sepsis, with like 34%. The MELD score, the average MELD score was 20.96, and then the Apache 19.6. But a lot of these studies can be, so one of the limitations of this meta-analysis is that all these studies had different inclusion criteria, exclusion criteria. Not all of them measured the MELD score, not all of them had the SOFA or Apache. So the conclusions, they say, they could not be really generalized to the whole ICU, like all ICU patients, all populations due to limitations of the study. Here's the graph that they showed where there was a p-value or statistically significant relation between thrombus and infection, ascites, and bleeding itself. So a lot of these patients, again, bleed and have thrombosis at the same time. This is another study, which was interesting because this is the only study, the big meta-analysis on heparin use for DVT prophylaxis in cirrhotic patients. So this was also, they looked at a lot of literature, and I think only 2 or 3 were kind of good studies to compare. They only included clinical trials. They had, which had prior diagnosis of liver disease, any stage of liver disease. They recorded the proportion of DVT and the proportion of bleed, and they had a control group which did not receive any heparin, and they had the group that received heparin. The hard thing about it is that we don't know how long they were treated for. We don't know the exact dose. They all use different dosage of heparin, so it was hard to compare. So as I said, they found 400 citations, but only 3 were good clinical trials. So I've highlighted here in this graph, it's a little bit of the characteristics, but I won't go into many details. But the colors show that only 1 trial had good comparison between bleeding risks and thrombotic risks, which is the bottom trial. All the others looked at bleeding, but didn't necessarily look at thrombosis, or were designed to look at thrombosis but not bleed. So they really didn't have a good population to make solid conclusions. So this is one of the graphs. So this is showing the odds ratio of the patients that developed thromboembolism in relation to the use of heparin. So basically their conclusions were, you can see the number of events per N, and it was not statistically significant, meaning that even though the patients got prophylaxis, they did not show statistically a reduction of thrombus. They did see a trend, but they concluded that maybe the size or the design of the studies, or the amount of studies included was not enough to make a statistically significant conclusion. And then on the other hand, this is the odds ratio of bleeding in the patients that received the prophylaxis. This one also, they did show that it was statistically significant, that there's not an increase, statistically significant risk in patients that receive heparin, although there were more complications than thrombotic events. These are basically conclusions of the study. And then, however, they had different baseline characteristics. They received what we talked about, different dosages of heparin. They were also outpatients versus inpatient trials. And then 3 of these included studies, they had control groups. And they mentioned that the control groups, although not pharmaceutical or drug prophylaxis, they did receive mechanical prophylaxis, or they were ambulatory. So it wasn't a clear control, like a very good control study. So in summary of everything that we've talked today, I think it's safe to say that cirrhotic patients are not necessarily autoanticoagulated. It's more of a rebalanced state, and we have to be careful about thinking they're autoanticoagulated. They are prothrombotic, and that causes a significant mortality and morbidity in these patients, including progression of their cirrhosis if they get portal vein thrombosis. So definitely, they're not autoanticoagulated. The INR is not a good parameter to measure coagulation in these patients. It has not been shown to be associated with higher risk of bleed. Being, high INR does not equal higher risk of bleed in these patients. The fibrinogen is sort of the best way to measure the risk of bleed at this point, and it's also been associated with higher mortality, probably because of higher risk of bleed or bleeding events in these patients. We have that hospitalized patients are at higher risk of DVTs compared to regular patients because of this prothrombotic state, or fine line, that whenever they have an inflammation, an infection, the inflammatory response is worse, so that balance gets tipped towards, thrombotic events. As I said, thrombotic events are significant because of morbidity. There's even a study that I read that patients are being treated with aspirin, these patients, to prevent progression, or it's shown to halt the progression of cirrhosis. And it's believed to be secondary to improving circulation in the liver and less like microthromba formation or less thrombotic events. Yesterday, in fact, a study came out. I received it. It's a gastroenterology magazine, that these patients should be treated for DVTs or PEs and even portal vein thrombosis like, there's no clear guideline. Like, once it happens, what can we do? Are we going to anticoagulate these patients? So yesterday, there was a meta-analysis that came out, and they say that, yes, we should definitely treat these patients. It's better to treat them with heparin rather than warfarin. But, that would be a separate topic. But just to point out the huge morbidity that this causes, that we're always afraid of bleeding, but we're not thinking of the morbidity of thrombus. And then there's no clear guidelines. As I said, we have to take it case by case. The best thing we can do is try to figure out what the risk of bleeding is for a patient. Like, do the benefits outweigh the risk to give the heparin or not? So we can do that. And then holding pharmacological prophylaxis in patient with platelets less than 50, that's just a random number. We've like read it in papers, or we think like, oh, well, platelets are less than 50, we shouldn't be given heparin. That is not based on science. A lot of the studies have mentioned that this is just a belief, or maybe physicians feel more confident about it, but it's not based on science at all. There's nothing to support this statement. Heparin prophylaxis does not significantly reduce the risk of DVT, but there was a trend, and maybe larger studies are needed to prove that it's significant. We don't know. These are all my references, and that's it. I hope you learned something. Any questions?
Anybody have any questions or comments? Yeah.
Bleeding always stops.
All bleeding stops. That's the surgeon's creed, right?
We're using heparin as unfractionated heparin, or as all heparinoids.
So that's the thing. They use different types of heparin, different dosages. So there's nothing really clear like what should we use. But definitely between heparin and warfarin, for example, in cases that we do have DVTs documented, heparin is proven to be better because it not only it's better for the progression of the clot, or also clears the clot up, versus warfarin that didn't show to be very good at that.
I don't suppose there was any studies that you came across that maybe stratified risk of bleeds based on either admission criteria, like if they came in with GI bleeding, or maybe variceal size. Because I feel like some people, like I would be much more nervous about anticoagulating people who had big, documented, juicy varices versus someone who just had like portal gastropathy. I just wonder if anyone looked at that.
Yeah, well, that's a good thing. So as I said, they're not standardized. They didn't go into details as to what the severity of the varices was, or like where the source of bleed was. Even at some studies, they just mentioned bleed or GI bleed, but were not very specific. They did mention platelets and like being the main conclusion that we should be optimizing the platelet number and function, but avoiding unnecessary transfusions of other blood products, because they often don't help and cause thrombosis rather than being effective with the bleed. The one that did show that was effective stopping the bleed was the tranexamic acid. That one works pretty well. But in terms of like the severity of the place of the bleed, not really. I didn't find out.
It's time to vote, I guess. Is it a myth? Patients with cirrhosis and prolonged INR are auto-anticoagulated, quote unquote, and do not need prophylaxis for venous thromboembolism. So how many think that this is a true statement, confirmed? How many people believe that people with high INRs due to cirrhosis are auto-anticoagulated and not at risk for thrombosis? How's that?
You can live with that.
Okay. Everybody live with that? So how many think it's plausible, and how many think that that's a myth? This is busted. All right.